Ladies and gentlemen, welcome once again to another episode of the Think Clinical Podcast. My name is Hamza. Good to be here once again. Thank you so much for all the support. If you haven't done so already, please remember to subscribe, like, and share. This is going to be another exciting episode, and today we are going to be looking at from the African market and from the African context. If you're a healthcare entrepreneur, what lessons can you learn from developed markets, and how can you better position yourself for all the challenges that these markets are eventually having, or the direction they've moved to over the last couple of years. So when you look at America, for instance, healthcare is consolidating at a breakneck speed. So at least 47% of US physicians were employed by hospital systems as of 2024, which is more than half of US physicians. And that was about 30% way back in 2012, which means this is going up pretty fast. So what can we learn from this? So we see that basically small practices are disappearing, and private equity owns everything from dental clinics to emergency rooms to the dermatology clinics to everything you can think about. Now here's the kicker. Multiple case studies have demonstrated how private equity ownerships have in many ways impacted the management and the style of building these clinics. Now you look at it differently as a clinician, and private equity will look at it differently from a business perspective. So why are we looking at this from the African context? Because Africa is about to face probably the same dynamic, and you need, as a healthcare entrepreneur, to be ready to position yourself better, to partner better with private equity, to be able to get yourself into that space and be able to avoid some of the challenges that physicians who own smaller clinics here have not been able to avoid, and hence where they find themselves today. Now the problem is that in medical school, we are not taught how to run businesses. We are not business people. So what we know is clinical care, and that's what we are good at. But it's time for you, and looking at how things are being translated, to be able to position yourself better, to be able to leverage when these investments come in at a later stage, because then you are well positioned as a business person and you can have those conversations. Now when we look at the consolidation story in 2024, private equity firms made 1,049 healthcare deals in the US, 166 leveraged buyouts, 262 growth investments, and 621 add-on acquisitions. Now, why? It's just the economics. Small practices can't negotiate with healthcare companies, and we're just too small. They can't afford the kind of technology they need to get to the next level, and they cannot compete on efficiency. That's just the challenge that small practices have. So they have to sell, and then hospital systems will buy these and add them to it, and private equity rolls them up, and so you have a physician who owned a small clinic now becoming an employee. And the impact of this is that the dynamics of how the clinic is managed changes, because if money is being invested into building this model, there has to be efficiency models in place to be able to recoup some of this money back. Quality of care in most cases is never compromised, because for the core of it, most private, most clinics and by most hospitals, by virtue of what they stand for, would always err on the side of making sure there's quality patient care, but at the back end trying to see how that can be provided in a more efficient way. Now, we need to understand that as practitioners in Africa, this is coming, and you need to be able to position yourself for this. Now, why do small practices need to operate like businesses? The practices that are surviving today in developed countries independently share one trait. They actually operate like businesses first, and then as clinics. Because the moment you lose that value as a business, then you get into trouble real quick, and everything that was sustaining you is down the drain. So here's what that means practically. You need to err on the side of operational excellence. You need to track every metric. your patient acquisition cost, your lifetime value, your no-show rates, your cancellation rates, your revenue per provider per hour. You need to track those. You cannot improve what you don't measure. Optimize scheduling to maximize provider utilization without burning them out. And then you need to negotiate supplier contracts aggressively. You need to be able to look into that. So inflation in healthcare is driven by labor supply shortages, forcing organizations to increase wages or lose talent to competitors. So all these things are coming to play. You need to position yourself better. Technology can also be an equalizer. In the US, millions of dollars have been spent on EMR systems. In Africa, tech innovations like field intelligence inventory management have transformed community pharmacy operations, right? So you can use affordable mobile first solutions built in the African context to be able to compete on the technology side instead of spending millions of dollars. And then you need multiple revenue streams. Most people and most successful independent practice don't just rely on patient visits. They are selling devices. They have wellness programs. You have telemedicine services, cosmetic and elective procedures, corporate wellness contracts. These are all in place to be able to provide value. Now, what we need to be looking at in the long term, as far as this is concerned, is that we have to be very clear on what we can copy as Africans and what to leapfrog. Now, this is what we need to copy: operational discipline. So if you look at BCG's 2024 outlook, they noted that surviving healthcare companies spent the past year making operational improvements, resulting in stronger business. So operational discipline is one of the things that you cannot compromise on. Metrics, processes, efficiencies, they work everywhere. You have to be able to keep track of that. This is something we need to copy. Technology-enabled care, telemedicine, digital health records, remote monitoring, these are important for you to copy. Specialized expertise, don't try everything at once. Own your niche. These are the three things that we need to copy. And as Africans, we need to leapfrog this. The heavy infrastructure. We build massive hospitals, and you can build distributed community-based networks with telemedicine backup at lower costs, right? Insurance-driven complexity, we need to move away from that. And then private equity consolidation, you have to look at how you position yourself better to be able to partner with PEs in the future if they ever come to you. How do you then build the future without repeating history? Now you need to understand that the money is looking, the private PE money is looking for opportunities to invest in. And soon that opportunity, depending on how we play our cards, it's inevitable, it's going to get to the African market. But the strategy is to build defensibility before outside capital arrives. You need strong community relationships, you need proven economic model, you need technology systems in place, and you need to provider networks formed. When consolidation pressure comes in, then you can negotiate from a place of strength, not from a place of desperation because you did not run your business well. Think in networks and not just silos. Private equity, public-private partnerships like the I3 African program successfully connected health with funding and partnerships, impacting 190 million patient visits annually. You don't need to own everything. Partner strategically, share costs, maintain independence, and then design for African advantages. Always think mobile first, think about building community trust, and think about flexible regulations. And then you have to always look at staying on your mission as a company and what that means for you. So the developed have spent over 50 years building their current healthcare system. They have made mistakes, they've created inefficiencies, and now they struggle to face them. We in the African continent have the privilege of starting afresh. Africa's population will double by 2050, creating a fertile ground for healthcare innovation. You can build what they should have built if they knew what we know now. Our system should be patient-centered, not insurance-centered. Technology-enabled, not technology-burdened. Outcome-focused, not transaction-focused. And it has to be sustainable, not extractive. Thank you so much, ladies and gentlemen. This has been another episode of the Think Clinical Podcast. Thank you so much and have a beautiful day.